Good morning, everyone. I'm pleased to be the facilitator of the Equity and Upstream Determinants of Health panel. As I said, I'm Jeff Capizzano, and essentially the goal of today is to bring the early childhood folks and the health folks together in conversations about equity and the social determinants of health. And so we have the panel here that's going to prime you for those conversations. And so what I'm going to do as facilitators, I'll start just kind of framing the conversation and defining social determinants, and then we'll turn it over to our distinguished panel. So if I can. When we talk about social determinants of health, we're talking about those determinants that are the non-medical factors of health, those things that are the conditions in which people work, grow, and live. And when you talk about it from an equity perspective, we're really talking about the circumstances of a person's life that are shaped by the distribution of power, about social influences, and about income. And that's sort of the focus of the discussion today. And when you think about what those factors are, it's income, it's education, it's housing, it's transportation. So I took the metro today. And I did that because, first of all, I felt safe doing it, and second of all, because I felt that it was going to get me here on time. And so that was an opportunity, a social opportunity for me to walk more than I would have if I got in my car. So these are sort of the social determinants that we're talking about. And when you talk about sort of upstream factors of health, these are the social influences, the governmental policies. You know, my background is in early childhood, and I spent 2 years in the Department of Health and Human Services working on early childhood policy. So, you know, we're thinking about sort of child care policy. We're talking about Head Start and how Head Start can influence the social determinants of health. So these are sort of some of the upstream factors that we'll talk about in a little bit. And the reason why we want to be talking about these upstream factors is that these are the pieces that we can actually move. These are the policies that we can change. And so they're profoundly important, and hopefully our discussions will be about how we can be working better to affect these different upstream policies. And so one of the things that I wanted to do is to try to give an example of what is a good example of upstream policies and how they affect health. And unfortunately, the one that came to mind immediately because I was watching CNN was Flint, right? So here's an example of a policy decision, the decision to take water from the Flint River rather than from Lake Huron to save money for the city. And it affected the water system because the Flint River is more corrosive and the lead in the pipes were getting into the water. And so what happens is you have a policy decision that ends up affecting a determinant of health, the water system, that ends up affecting the health of children with the lead levels. And so, you know, I was going to stop there, but I didn't want to leave you with a picture of a dirty water bottle, so I wanted to give you a sort of a kinder, gentler example. And, you know, this is my field. Early childhood is a social determinant of health, and here we have, you know, the first lady in an early childhood program. And essentially, when you think about the things that high quality early care and education can do, you know, they affect all sorts of aspects of a child's health, from the child's stress level to a child's eating habits, and all of the things that happen later in life with regard to higher incomes and reduction in substance abuse. And so that's just kind of a really quick overview of the social determinants of health. And when we think about what these upstream factors are supposed to be doing for children, they're supposed to be doing a few different things. The first is, you know, they're supposed to be just decreasing these community risk factors. They're supposed to be increasing income and decreasing poverty. They're supposed to be, you know, decreasing crime, promoting environmental factors that promote health. They're supposed to be increasing all of these protective factors with regard to education and income that increase the resiliency of children. And so just some food for thought as we move to our speakers. We have two amazing speakers. The first is going to be Dr. Bill Dietz.
Well, thank you, Jeff. And it really is a pleasure to be here to address what I think is really a very difficult topic. Health inequities are easy to describe, but it's pretty hard to figure out how we approach those. And what I thought I would do is to focus on a specific example that will help illustrate, I hope, the role of inequities and upstream determinants of health. I'm going to do this in the context of adverse childhood experiences. The exposure to the long-term consequences of exposure to adverse childhood experiences is something called toxic stress. I'm going to point out at least two cycles which perpetuate toxic stress, those across generations and those that cross individuals with communities. And then finally, I'm going to emphasize that kind of interconnectedness and point to some potential ways that we can begin to engage. So these are adverse childhood experiences. They go from verbal, sexual, or physical abuse through other exposures like hunger, homelessness, incarceration, household instability like mental illness, divorce, and drug or alcohol use. And it's important to remember this list because these translate into the adult expression of adverse childhood experiences and are reinforced by adverse community experiences. So there's this alignment between the individual exposure, the transgenerational exposure, and the community experiences. These are widespread, very common. And the consequences of adverse childhood experiences rise in direct proportion to the frequency of exposures. A large number of children have exposure to at least one of these, but many have exposure to two or more. But it's important to emphasize that this is a continuous distribution. It's not a stratified distribution. Now, remember that early slide about what ACEs are. The consequences of exposure to ACEs, as they are expressed in adulthood, are associated with many of those same behaviors that children were exposed to in early childhood, such as illicit drug use, alcohol abuse, attempted suicide, depression, and, relevant to this conference, severe obesity. There's an important article that I didn't bring a slide from, but there's a very nice illustration of the transgenerational transmission of adverse childhood experiences in a New England Journal article in 2014, October 2nd, which tracks three generations, three individuals representing three generations within a family. And what's stunning about that illustration is that these experiences are repeated generation after generation. Now, specifically with respect to obesity, there's a 40% increased risk of obesity in anyone exposed to these, and a 90% increased risk of severe obesity, which is a particular problem because severe obesity, about half of severe obesity begins in early childhood or has obesity of onset in childhood. And notice that 20% of severe obesity in adulthood is associated with these early adverse childhood experiences. Now, one of the things that, one of the areas of focus today is what constitutes resilience, because plenty of children are exposed, but not all of those children go on to experience these types of adult consequences. And one of the challenges is how do we build individual resilience? How do we build that individual resilience in the context of adverse community experiences, which are working against the capacity of individuals to themselves develop resilience? So one of the key elements of how to address these areas we began to articulate in this article that we published in Health Affairs in October. This article was originally about obesity and other chronic diseases, but it makes the point that unless we begin to integrate the individual approaches that we have, the clinical approaches, with community systems, we're not going to succeed. And all of this turns on our ability to engage individuals and families and empower them. And that's what it's going to take to make them nurturing parents to foster childhood resilience. And it's important to point out that there are at least 3 historical legacies that are working against us in this regard. The first is the legacy of violence and oppression that's affected African Americans particularly, but Native Americans and Hispanics. The second is an important shift in emphasis that occurred in the 1970s when Walter Mondale proposed the Child Development Act, which would have really focused a lot of federal resources on preschool development. Nixon was diametrically opposed to that, and so in a counter to that, Mondale proposed the Child Abuse Prevention and Treatment Act. So in that sense, the emphasis was shifted from a broad perspective on child development to more of a focus on the individual children who were abused and often ended up in emergency rooms with fractures and other evidence of violent abuse. And all those, by the way, are just the tip of the iceberg in how adverse childhood experiences express themselves. The third legacy is a series of federal, state, and local policies which began to isolate these minority populations in communities which were bereft or lacking in resources. So that the poverty that we're seeing in these communities is not just a consequence of, or I should say it's a deliberate consequence of these policies which fostered housing in contained neighborhoods without, that were segregated. And therefore lacked the kind of resources. So when we talk about this integration, it's important that we begin to address these community systems. The other point that needs to be made is that if we only focus on the care delivery system, if we only focus on those children who have been exposed, we're not going to succeed because they don't have this kind of supportive system. And the investment in addressing abuse and adverse childhood experiences as it's expressed goes through the legal system. In Massachusetts, it's the Department of Children and Families, and it's largely a punitive and family disruptive initiative or strategy, which only reinforces the kind of disruption that families are already subjected to. So what are the adverse community experiences that foster adverse childhood experiences? These are derived from a really important paper that was pivotal in my understanding, and fortunately it came out just in time for this discussion. This is a paper from the Prevention Institute published a week ago entitled Adverse Community Environments. And it focuses on people, place, and equitable opportunity. So in the socio-cultural environment, the adverse community experiences are characterized by disconnected social networks, which in turn are a consequence in part of the high levels of incarceration in those communities, low collective efficacy and low political efficacy. So this speaks directly to the lack of empowerment that characterizes many people in these communities. Place is also important. There's deteriorated housing, dangerous safe places, as was mentioned yesterday, all of which foster an increased stress on the part of people living in these communities, including the people that staff or many of the people who staff our early care and education centers. And finally, the intergenerational poverty is promoted by unemployment and the limited opportunities for jobs. So if we're going to build individual resilience, we have to talk about how to build community resilience. And these are some strategies. It's easy to describe what we should do. It's harder to describe how we do it. And I think that's a profitable area for discussion in some of the breakout groups. So beginning by fostering political and social engagement, which in turn may enhance the development of social capital and social networks that allow people to bounce back from the adverse community and childhood experiences. Organizing community activities. It's interesting that Flint is back in the news, but about a decade ago, Flint was notable because the city took over destroying or raising the vacant homes and converting those to community gardens, which in turn build social capital in those communities. So the kinds of community activities needn't be directed at adverse childhood experiences directly, but other activities which engage people in their neighborhoods are probably the way to start moving towards increasing the social connectedness. And finally, changing the narrative from one of hopelessness to one of resilience. And that's a big lift, particularly in Native American populations for whom alcohol and obesity and early death has become the norm rather than the exception. Place is also important, and several of these areas were mentioned in the panel yesterday afternoon: improving the quality of the built environment, parks, housing, safe parks, housing and transportation, as you pointed out, Jeff, and reclaiming, improving, and ensuring safe public spaces. The final strategy around opportunity is to begin to shift the norms around conflict resolution so that it's not violence begetting violence, but other ways of solving those problems. But without that economic empowerment, workforce development, job availability, this is going to be a hard area to work on. Now, there are a number of potential institutions which can foster community resilience and also address adverse childhood experiences. At the top of the list is churches. I don't think that we've engaged churches around this area. Community-based organizations were mentioned yesterday, and Dr. Koch's example of child health workers is one of those initiatives. And I must confess that I'm not intimately familiar with that strategy, but it seems to me that it's not sustainable. I mean, most of his work was supported by grants, and I gather that there are state funds available for community health workers, and that would be an important initiative. Community projects like gardens I've mentioned, not that gardens are going to solve the nutritional issues within communities, but as a way of engaging people with each other to foster social capital. And cultural rituals, I think, are more prevalent in the Native American community than in the African American or Hispanic community, but that may only reflect my ignorance of those cultures. But to me, one of the most intriguing opportunities is the thought that about hospitals as anchor institutions. This comes out of a paper that Tyler Norris published about 6 months ago, which pointed out that hospitals bring to communities a variety of resources. So community health needs assessment and community benefits initiative are one example of the kind of financial investment that hospitals can make in communities. And there's several examples in this manuscript or this white paper of examples of how hospitals have invested in communities. So that, for example, the Cleveland Clinic has built low-income housing in a really deserted area near the clinic as an example of that type of financial investment. Hospitals also do local purchasing, or also do purchasing. It can be local, and that would in turn foster jobs and opportunities. Hospitals are also employers, and hospitals can train people. So I think this is one of the untapped opportunities and one of the big institutions which potentially could make a difference in these communities. And given the Affordable Care Act, which increasingly reimburses for value-based care, so it's not volume-based care, but more dependent on outcomes, offers a potential mechanism to pay for hospitals' engagement in these initiatives, simply because the impact of these areas are on upstream determinants of health, and if health is the measure that hospitals and medical plans will be reimbursed for, this is an opportunity to identify a source of payment. So, in closing, adverse childhood experiences exist within the context of adverse community experiences. It's transgenerational in nature. If we focus only on the child who has been physically abused, we are only treating the tip of the iceberg. And the investment in treatment has largely been on the medical side and is highly cyclical, that it rises when there's been the death of a child in custody and then disappears thereafter. And I think we need to, at the federal level, work to revisit the Child Development Act in the 1970s as a way of beginning to address the upstream determinants of adverse childhood experiences and adverse community experiences. Thank you.